All right, we're a minute after, so I'm going to go ahead and get started. I'm Lisa Chamberlain. I'm our Associate Chair of Policy and Community Engagement, as well as a general pediatrician in the community. And I am thrilled today to be helping to moderate this session, COVID-19 in Children, an update and seminar, and very excited to be able to learn today from Dr. Maldonado, who I'll introduce in 1 minute. Wanted to point out that there is a text code there and the number to send it to in order to claim CME credit for this hour. Please do so. That information will be available in the not chat function, the Q&A function. And if you do have questions, please do enter them in the Q&A area. So with that, let's get started. I'll introduce Bonnie. And Bonnie, I believe you're sharing your slides. So while you are switching those over, I'll go ahead and introduce someone who really needs no introduction. Dr. Bonnie Maldonado is our Senior Associate Dean and a professor, both in the Department of Pediatrics and the Department of Epidemiology and Population Health. She is also the Chief of the Division of Infectious Disease and our Director of Global Child Health. At the Pediatric Academic Society's meetings just a few weekends ago, she was honored by the American Academy of Pediatrics with their highest honor in terms of service. And so we are very honored to have her with us here today. I think of her in her role today mostly as continuing to be the captain of our Packard ship as we navigate this COVID pandemic storm. Bonnie, we're all so indebted to you for the literally countless hours you have spent helping us process all this. And as we do move into this next phase, we are all very excited to hear your updates and thoughts on COVID in children. So thank you, and excited to hand it over to you now.
Well, thank you, Lisa. I want to thank Serene and Ingrid as well, because I know they've been really keeping us as organized as we can be. I want to thank all of you because I tell my husband, I'm just representing the work that all of you are doing. I'm really just trying to reflect everything that you're all doing. So as much as I can be a clearinghouse to provide feedback for you and the work that's going on, I'm so honored to do that. And so glad to see that Packard has been so well represented overall in our national pediatric leadership with Mary and Lisa and Christina Alvira and Fernando and so many others. So thank you for that. But I'm just one member of this amazing faculty. So I want to get to the program here because there's quite a bit to cover, and I hope I don't go too fast, but I want to check in because it's been a while. So I'm going to cover a little bit about COVID-19, really obviously as it relates to children, and then talk about the vaccines. If I have time, I'll talk a little bit about antiviral therapy. There's unfortunately not much to say, and then we can hopefully take some questions. So here are my disclosures, working with Pfizer as well as with NIH on some of their antiviral oversight of their trials now. So as we all know, we are very, very close, depending on how you count the numbers, to having 82 million cases recorded in the US with almost 1 million deaths in our country. And you can see down at the bottom that we are having a bit of an uptick right now with this Omicron subvariants, but we're actually not doing too badly because we are not seeing as much hospitalization or death residual from these infections, and some of that may be some cross-reactive immunity with Omicron that's really helping to protect us. But we'll just have to see how we go in the coming weeks as we progress through this, whatever this mini surge, hopefully mini surge might be. So I really want to bring you back to the aap.org website because they do a great job of putting together a twice monthly report. This is the most recent report from May 5th. They come out every Thursday at aap.org, and you can click on a number of links to COVID resources, but just to show you that we have a cumulative over 13 million children who've tested positive in the country since the beginning of the pandemic, since reporting began for the pandemic, with about 60,000 plus cases reported in the last week. So we are up a bit, and I'll show you that in a second. Over 44,000 hospitalizations, and unfortunately, almost 1,100 deaths in children reported. Now, the numbers differ depending on the source, but at least 1,068 deaths so far. And you can see here again from AAP up on the upper left that we're seeing a little bit of an uptick. And if you look at the wbe.stanford.edu website, that shows you our real-time daily and environmental surveillance tracking that we're doing here. We actually do it for the whole Bay Area, so it's really helpful to be able to see what's going on in the community. And we did see a pretty high rate rise in the last 2 to 3 weeks. That seems to be stabilizing and even dropping a little bit here in the area. So I think that surge at least for now, looks like it's starting to come down. But you see where we were overall nationwide with kids. And then you see that children overall have been, throughout the pandemic, have made up about 15 to 20% of the overall number of cases in the entire population. And when you look at vaccinations, you see that we are overall doing well with vaccinations. Over 220 million people have been vaccinated, with 750 million doses of vaccine distributed around the country. However, those numbers are really not reflected in the pediatric population. So you see that overall, we have about 95% of our population over 65 vaccinated, but that number is pretty good overall until you get to children. And I'll show you that in a bit. Now, here is a nice resource from the CDC websites, which I think we're starting to see a normal kind of vaccine schedule that people can look at. So here you have on the column up in the far left, Pfizer vaccines for 5 to 11-year-olds, Pfizer vaccines for 12 years and older, Moderna vaccines for 18 and older, and then a Janssen vaccine for 18 and older. And you see that you can give a second dose there for the littlest, the 5 to 11-year-olds, 3 weeks after their first dose. The second dose can be 3 weeks after their first dose. But for the 12 and older, you can give the second dose between 3 and 8 weeks after. And I don't have time to really go over that, but we talked about that before. I think that means that you want to mitigate some of you actually can improve your antibody response. And there's some evidence that you can actually mitigate a little bit of the myocarditis risk. As low as the risk is, it seems to mitigate if you wait a little bit longer. So 8 weeks after the first dose seems to be an ideal time to give 12-year-olds and older the second dose. And then a booster can be given for 12 and older at least 5 months after the second dose. For Moderna, you can give a second dose 4 to 8 weeks after the first dose, and a booster at least 5 months after the second dose. And then finally, Janssen, where really the FDA is not recommending that as a primary series anymore. But if people have received a dose, they should get a booster at least 2 months after, and they should not be boosted with Janssen. They should be boosted with one of the other mRNA vaccines. And again, from the CDC website, you can see that the recommendation is that all people 12 and older should receive a booster of a COVID vaccine after completion of the primary series, even if they were younger than 12 at the time of their primary series. And some adults may receive a second booster. If I have time, I'll go through all of that information at the very end when I talk about boosters, if we have time. But the other thing to remember for pediatrics is that second arrow there, that second blue arrow. Children 11 and younger are currently not authorized to have boosters, and we will see if FDA and CDC do recommend boosters for the under 12-year-olds, that those data were submitted to the FDA. So we'll see what the recommendations are in the coming weeks. It's going to be quite busy in the next several weeks. So here's just a timeline, because I know it's confusing, and this has to do with how we measure efficacy over time and effectiveness over time, because the different vaccines were authorized at different times for different age groups. So the FDA issued its first EUA for people 16 and older in December of 2020. The vaccine, unfortunately, I don't know if you remember this, it's only been a year. It feels like much longer than that, but it's really only been a year since we were really vaccinating people in a large scale. And even about a year ago at this time, we didn't even have enough vaccine for all of our healthcare workers and people over 65. So we were really struggling even a year ago. So I think it's important to put that in context when we talk about boosters for the younger kids, especially. So then the FDA approved the Pfizer BioNTech vaccine for 12 to 15-year-olds. This is all EUA use, emergency use, in May of last year, so just about a year ago. So kids 12 to 15 have been able to get vaccinated for about a year now. However, for kids 5 to 11, the Pfizer vaccine has only been available since October of last year. So really only about 8 or 9 months or so. And as you know, I'll show you the timeline for consideration of the younger ages in a bit. So let's look at where we are right now. This is from the American Academy of Pediatrics, aap.org site. And this is the status as of last week. As I said, these get updated every 2 weeks. So unfortunately, this number has been very stagnant. So we have only seen about 8 million children, who are 28% of 5 to 11-year-olds, who are fully vaccinated in the US. And only about 58% or 14.6 million 12 to 17-year-olds have been fully vaccinated. So really relatively low numbers compared to what we're seeing in older adults. And here on the left, you can see the numbers for 5 to 11 at the top and 12 to 17. So you can see over time, there's just not a lot of enthusiasm, it appears, for getting vaccinated in both of these age groups. And interestingly enough, this is an older Washington Post take on a CDC report looking at seroprevalence of infection. So actually measuring infection, not just spike protein antibody, but measuring nucleoprotein antibody, which is a measure of true infection. You can see that the highest seroprevalence is over 50%. It's about 58% of kids under 17 have already been infected. You see that really went up during the Omicron period. And the older you are, the lower your risk of already been infected. And this is also inversely proportional to how many people are getting vaccinated. So while we don't have direct evidence that vaccination prevents infection per se, there is some indirect evidence that vaccinations do play a role in preventing some infections, but certainly prevent hospitalizations and deaths. This is just another slide, the two at the bottom, showing the cumulative number of kids vaccinated on the left, 5 to 11, and on the right, 12 to 17. So you can see we went up fairly rapidly at the beginning of licensure or approval, EUA approval, but really have been stagnant for many months now. This is a study that was published actually in January of this year, but really available online in October of last year, for a study of the Pfizer vaccine for kids 5 to 11. And this was really the study that led to approval for the 5 to 11-year-olds back in October of 2021, where 3,000 plus children were vaccinated with a vaccine efficacy rate of 91%. And you could see in the upper right the Kaplan-Meier curve, and you could see that there were 3 cases of COVID-19 SARS-CoV-2 infection in the vaccinated kids, compared to the 16 cases among the placebo recipients. And so the serious adverse events we saw were equivalent in the vaccine and placebo groups, with there was a more common fever, low-grade fevers, headaches, and flu-like symptoms among the vaccinees compared to the placebo recipients. But here is our own experience here at Stanford, and you may have seen this picture before, but this is one of our little participants, and this was on blinding day last September, when the kids were unblinded to see if they'd gotten placebo or vaccine, because obviously the placebo kids needed to be vaccinated. So she and her family have been very happy, and they just got an update yesterday. She actually used the vaccine study as her science fair project, and she won first place for that. So she was very happy to show us that she had really been enthusiastic and has done well. She actually was in the, I recall that she was in the vaccine arm. So she was quite happy and was able to really make this part of her academic experience. So let's go over the COVID vaccine update so far. I know it's been very confusing for all of us. So if you look at the Pfizer BioNTech product, it is currently fully licensed, BLA, fully licensed for people 16 and older. So this is available to anybody. It's called Comirnaty, that's the trade name. But it's authorized under emergency use for 5 to 15-year-olds. And for 6-month to 4-year-olds, there will be possible resubmission to FDA next month. Obviously, the company has said they are going to submit, but we have to say possible because we don't know for sure what's going to happen. Moderna has also been licensed for people 18 and up, and they are have submitted for 12 to 17-year-olds for emergency use authorization last June of 2021. They have, and I'll show you some updates that I just got this morning about this information. They've also are going to fully submit for 6 to 11-year-olds and for 6-month to 5-year-olds. And we anticipate that that will happen this month. And I'll show you what the FDA may be planning to do with that information. And then finally, Novovax is a separate vaccine. It's a conventional platform vaccine, and it's a subunit vaccine. And this is this vaccine is really been studied primarily in 18 years and older. So with a submission for emergency use authorization consideration in the US, although it's interesting, we'll find out more, but our understanding is that Novovax doesn't plan to roll it out in the US, but they are submitting for EUA. So, but we don't know that for sure. They may actually consider using it in the US as well. But there's also data on 11 to 17-year-olds. So I'll show you a couple slides on that. And we don't know when the data for the time for submission to FDA will be for that indication. So this morning, I saw this from Reuters, and it says Moderna completes all FDA submissions for use of its COVID-19 vaccine in adolescents and children. So they've made all the necessary submissions for adolescents 12 to 17, children 6 to 11, and children 6 years to 6 months of age. And that was done actually on Monday. And this just came out today from Reuters. So, or yesterday, sorry. So we're going to see what happens with that. And basically, this was put together about a week and a half ago from the FDA. This is from the FDA website. And here's what their tentative plan is. And I want to give a shout out to Haley Gans because she is on this vaccine advisory committee for the FDA. And the plan so far is to have a June 7th discussion around the Novovax vaccine for people 18 and older that I just mentioned. But then June 8th, 21st, and 22nd, they will be quite busy discussing updates to the Moderna and Pfizer BioNTech emergency use authorization for the COVID-19 vaccines for 6-month-olds and older. So it looks like we will have the month of June to really finalize, I think, what the FDA will do with vaccines for kids for both Moderna and Pfizer. Now, right after that, I also want to give a shout out to Grace Lee, who's the chair of the ACIP at CDC, because she will be chairing after these meetings, we think, discussions around how to provide clinical guidance regarding the FDA decisions on pediatric vaccines. So, and then there will be one final meeting, well, not one final meeting, but another meeting in June on the 28th. And that will be mainly focused on discussing SARS-CoV-2 strain composition for vaccines and whether or not there should be vaccine modifications for fall of 2022. So it looks like we're heading into a influenza-like model where there may be strain composition selections for ongoing use in the fall season. So we'll stay tuned for more information there. Now, when we talk about vaccines and effectiveness, efficacy, et cetera, we don't always, in fact, we rarely do studies where we have the luxury and the privilege of being able to do efficacy trials, because efficacy trials require lots of cases of disease, as you know, because you have to compare the number of cases in the placebo group or the control group, whatever that is, compared to the intervention group. So if it's one new vaccine compared to an old vaccine, or a vaccine compared to placebo, you have to have enough cases with enough power to detect efficacy. Now, we generally don't have enough cases of disease to do that with most studies, unless you enroll, for example, 40 or 50,000 people like they did with the earlier COVID vaccine trials for adults, or like we did for Prevnar, all the pneumococcal vaccines, like we also did for the rotavirus vaccines, where they studied thousands and thousands of people to look for cases and then efficacy. So in order to get better, rapid, but yet scientifically robust approval, most vaccine trials use immunobridging studies, and these are clinical endpoint efficacy trials, which are efficacy estimate. Well, the highest standard is to use efficacy estimates by comparing rates, as I mentioned earlier. But immunobridging studies are inferred efficacy, and this is what we generally do for most vaccines, because we really can't, we don't have the bandwidth always to enroll thousands and thousands, like we're talking tens of thousands of people into each arm to look at true efficacy. So what is done then is looking at comparing neutralizing antibodies, that is geometric mean titers or seroresponse rates, between the population of interest and a comparator group for where you already have efficacy known. So in this case with COVID, we've already had thousands and thousands of adults who have had efficacy studies done. Over 100,000 people have been in these trials, mostly over 18, but some with as young as 16 to 25. So we already know efficacy in those groups, and we use that as historical controls regarding their neutralizing antibody response and the comparator response in our younger kids to infer that neutralizing responses are equivalent to efficacy. And in general, that has worked well for most pathogens, for most vaccines, and certainly has been really correlating well so far with the COVID-19 vaccines. And the criteria, I won't go through too much detail here, but have to do with these vaccines. They don't use geometric mean titers, which is what we're used to. They're using geometric mean ratios. So they're comparing the ratio of the kids to the existing data we have on older and young and old adults. So they look at a ratio of 0.67 or a ratio of 1.0 or better when they look at what we call non-inferiority. So that is the antibody rates are equivalent, and therefore we think they're going to be just as good at protecting these younger kids as we see in the older ones. If there are cases of disease, then certainly efficacy can be utilized, but we can't always count on that. And then finally, the seroresponse is usually, when you look at those differences as well, seroresponses are thought of as a 4-fold or better increase in 50% neutralizing antibody titers. So having said that, here is the study that was published last year for teenagers for the Pfizer vaccine, looking at vaccine efficacy. And you can see here for the number of participants, which was over 1,000 adolescents, you 12 to 15 years of age, you see that there were no participants who had a COVID-19 occurrence in the vaccine group here on the, and my pointers, there it goes. You see no cases in the vaccine group here, but you see 16 cases of COVID in the placebo group, and 18 if you count the 2 cases that occurred in people who had evidence of prior infection. So that led to 100% vaccine efficacy rate. So there, because we still had a more circulation of virus, we were able to, they were able to identify true efficacy estimates, which were pretty robust and were 100%. Now, this was well before Delta. This was right at the beginning of, this is before Delta and Omicron. And you can see here that the ratio, the geometric mean ratio of neutralizing antibodies was high. It was 1.76. So that is the 12 to 15-year-olds had a 76% higher antibody titers compared to the 16 to 25-year-olds, which we knew already had good efficacy. And then when you look at the data for our study, that like I showed you in the little picture there of our little participant, here's the 5 to 11-year-old data that was published in January of this year, but actually was released in October for the FDA to review. And you can see here that the geometric mean ratio compared to 16 to 25-year-olds of neutralizing antibody was equivalent. It was 1.04. So essentially had the same geometric mean titer as the older children and adults. And you can see here for the same study that there was no difference in the seroresponse rates, 0% difference in seroresponse rates. So basically about a 97.2 to 3% seroresponse. So virtually almost everyone responded. And then finally, as I showed you earlier, here's the 91% efficacy that we saw. 3 cases in the vaccine group in the red and 16 cases in the placebo group in the blue. And this was for the, this was again, what led to 5 to 11-year-old approval under EUA. Now, when you look at US teen effectiveness, so now we're going to track over time, you can see that vaccine effectiveness against COVID among hospitalized patients 12 to 18. What you do here is you take people who are hospitalized with COVID, and then you ask them, are you vaccinated or not? And your vaccine effectiveness is really a simple calculation of how many people who had COVID and were how many people had COVID and were vaccinated divided by how many people had COVID and were not vaccinated. There's more to it than that, but that's essentially how you calculate effectiveness. And you see that this was before Omicron. The vaccine effectiveness in teenagers of the Pfizer vaccine was 93% overall, with very similar findings for 12 to 15-year-olds and 16 to 18-year-olds. And now here, if you look at severe disease, this is even more telling because you can see that if you look at the vaccinated versus the unvaccinated, fully vaccinated versus unvaccinated, you see that virtually everybody so there was nobody who was fully vaccinated who was in the ICU or had critically ill outcomes. And patients overall who were hospitalized were actually more likely if the 6 kids who were vaccinated who were in the hospital were not in critical condition, but even their length of stay was shorter than the length of stay for those who were unvaccinated. So again, this is a good measure of effectiveness pre-Omicron. And you see here reflected very similar information where on the right, you see effectiveness overall in each of the different age groups from 12 to 18, broken down by the 2 age groups. And then for those who are partially vaccinated and also looking at severity of disease. Now here, when you look at effectiveness of the vaccine against, vaccine against Delta, because again, Delta came over the summer of last year, so that other paper didn't really cover that. This is a study, a larger study from 31 different children's hospitals around the country. Unfortunately, we weren't one of those hospitals, but this is from hospitals, even several in California as well. You see that the overall vaccine effectiveness was 90% there for documented infection and 93% for symptomatic infection. This was pre-Omicron, but included Delta. And then here is another study. I'm sorry, this is the study with the 31 pediatric hospitals around the country. And you can see from July through February 2022, which was pre and including Omicron, we saw that the effectiveness versus hospitalization fell with Omicron, with teens showing 92% effectiveness with Delta compared to 40% with Omicron, but effectiveness of 80% versus critical disease in that age group. And then in the 5 to 11-year-olds, we had 68% effectiveness during Omicron. Now, however, unvaccinated kids had worse outcomes. So 86% of the deaths were in the unvaccinated, 96% of the kids on ECMO, 92% of children on ventilators, and 88% overall of hospitalized children were unvaccinated. So still, while we did see a fall in Omicron effectiveness, we still had better severity scores. And here you can see a summary of that, where you see effectiveness in different age groups. And you see during the Omicron period, you drop off in effectiveness, but even the 5 to 11-year-olds seem to do pretty well, but definitely seen some drops here. And actually no real difference between 5 months to more than 5 months since vaccination for Omicron. When you look here at further along at adolescents, 12 to 18-year-olds for Delta, you see very good data for Delta critical, non-critical COVID effectiveness. Omicron starts to drop off, as we talked about, but you see for critical COVID-19 with Omicron, we have very good protection still, and it really tends to be more of the non-critical cases. And when you look here at efficacy of the vaccine in adolescents for the geometric mean ratios, we're looking at effectiveness. So the geometric mean ratio in adolescents and young adults 12 to 18 is very good compared to 18 to 25-year-olds. So we know from an antibody perspective, so we've already looked at effectiveness, but from an antibody perspective, we're getting very good response rates as well. And here is another slide showing, the other data were for Pfizer. This is the Moderna data. So now we're switching to Moderna, which has not been approved yet, but this is just a partial snapshot of what the data is going to look like when presented to the FDA. So you see that serologically, the Moderna vaccine works quite well. It's non-inferior to the what the experience has been in the adults. Now, when you look at additional data from the Moderna vaccine trials in adolescents, you can see that efficacy there after the second dose is quite good. You do see that it drops off a little for SARS-CoV-2 infection, but still quite efficacious, and drops off again a little bit for asymptomatic infection. But that's been true overall as we've moved along in the pandemic. So the top line data that were released that I showed you there were released in October of 2021. And I'll show you the manuscript, which actually was just released yesterday. So I had to put that slide together really quickly last night. It's a little messy, but I wanted to show it to you. So they used a 50 microgram dose in this in the 6 to 11-year-olds. And these were healthy kids. They gave the doses 28 days apart. It was about 4,700 participants, and they met their primary immunogenicity endpoints. That is, their geometric mean ratio of neutralizing antibody was 1.5 so 50% better than the older population. And the sero response rate was 99.3%, which was very similar to the older children and adults. And the safety profile was consistent with what's been seen with other populations. So again, milder, moderate in severity with fatigue, headache, and fever being the main ones, and no myocarditis or related SAEs. So here's the actual paper. It was published yesterday. With in this paper, there were 416 people in children randomized to 2 injections of the 50 microgram product. Again, you saw the transient, mostly associated with low-grade transient adverse events, with no vaccine-related serious adverse events. And you see there that the serum neutralizing antibodies were equivalent, 1610 versus 1300 in the young adults, with serologic responses of 99% and estimated vaccine efficacy of 88%. So actually did quite well, and we'll get a chance to review those data through the FDA and CDC next month. So here's additional data for the 6-month-olds to 5-year-olds, and this is really Very preliminary data just released. Top line meaning they just give a high level. This is literally almost all we know. So we'll see more of this data from the FDA and CDC meetings next month. We don't have a manuscript yet, but in this group, and you'll see this a little bit more detail later, 25 microgram doses, 28 days apart, 4,200 children in the 2 to 5-year-old age group and 2,500 in the 6 to 23-month-olds. And they did meet their primary immunogenicity endpoints. The geometric mean ratios compared to 18 to 25-year-olds were very good at 1.3 and 1.0 ratios compared to those older young adults. And the tolerability in terms of the adverse effects were very similar. Fever was consistent with other pediatric vaccines, with a fever in the 6 to 23-month-olds of 17% and 14.6% in the 2 to 5-year-olds. And there was very little fever over 40 degrees in each of those groups. So again, 6 months to 5 years of age. Here's the efficacy during Omicron. So in the 6 to 23-month-olds, the efficacy was 43.7%, so low compared to pre-Omicron, but very similar to what we saw with Pfizer in adults and children. And for 2 to 5-year-olds, the efficacy during Omicron was 37.5. The majority of cases were mild. There were no severe diseases, COVID disease cases observed in either age group. And because there was absence of severe disease, hospitalizations, or deaths in this population, really efficacy is going to be otherwise for those endpoints, it's going to be hard to calculate. So efficacy will really have to just be against actual infection. So here's a little bit of data on the Novovax vaccine, which the data were released this February. This was a study done in 12 to 17-year-olds, about 2,200, with a 2-to-1 ratio blinded crossover design. There was a demonstration of neutralizing antibody non-inferiority compared to 18 to 26-year-olds. So that is 1.5-fold higher antibody responses in the adolescents compared to the young adults, which met FDA criteria. And it looks like there was about 80% efficacy overall and 82% against known Delta variants and consistent across age groups. So we'll need to hear more about Novavax because we don't have a lot of experience. We don't have any experience really in the US with this vaccine. So learning about what experience has been in other parts of the world. And this will be discussed next month in early June at the FDA. And here you can see the data on the antibody titers that I talked about, 1.5% geometric mean ratio and 1.1% difference, which means they were essentially equivalent to the older older adults. And you see that most of the cases in the placebo versus the vaccine recipients were mild cases overall. So in summary, for the Novavax, the vaccine was well tolerated, no safety signals were identified, and there are plans to supplement global regulatory filings in the first quarter of this year, but that didn't happen. The first quarter passed, so it looks like we will actually get to see the data early second quarter of this year. And they are going to continue to study additional groups in additionally younger age groups over time. And then here we're going to see data on boosters very quickly. So here's safety monitoring of the vaccine. The booster data is primarily going to be Pfizer because that's the one that's available right now. So you see for 12 to 17-year-olds, the table on the left shows most of the reactions, which are all the most common reactions. The main issue is we know what happened after the second dose. Is the booster going to provide more reactions, less reactions, or the same? And what you see is that the reactions to the booster in the 12 to 17-year-olds was similar across the board. So they were very similar. In particular, people were worried that they might be more rebound reactions to a booster, and that did not happen. There were actually fewer cases of myocarditis with 32 confirmed, so 11 per million doses. These were all boys, 84% hospitalized, all recovered or recovering, and no deaths. If you look at 5 to 11-year-olds, now we haven't had a chance to really look at this very well because 5 to 11-year-olds haven't had this is not only safety overall because this was approved in October for 5 to 11, we don't have time yet and we don't have boosters approved, and we haven't looked at booster data yet in this age group. But after the 2 doses of vaccine in the 5 to 11-year-olds, you see that after 8 million doses, there were 11 cases of myocarditis, all recovered or recovering. There were 2 deaths, but these were not related, deemed not to be related to COVID or the vaccine. And those 2 cases were in medically complicated children. And then here is a little bit of, this is a complex slide. I'm sorry to show it this way, but essentially it looks at cardiac complications after SARS-CoV-2 infection compared to mRNA COVID vaccination. And here you see in the table, SARS-CoV-2 infections. Here are the rates of SARS-CoV-2 infections and complications, myocarditis, pericarditis, or different combinations. And the numbers are here. These are rates. And here you see the incidence among males of these complications after the first dose, second dose, unspecified dose, or any dose of the Pfizer vaccines. And then here you look at the risk ratio of myocarditis or other signals around cardiac complications, comparing SARS-CoV-2 infection with either the first or second dose. And you can see here in the black that these are the highest rates of complications, cardiac complications, among the vaccinated kids. And even there, the risk is actually 2 to 6 times higher among SARS-CoV-2 infected individuals compared to vaccinated individuals. So, and the risk, of course, is highest here in this age group, which are the 12 to 17-year-old males. So again, very safe, but again, we want to make sure people understand that this is very, very rare, but definitely proven risk in that age group. So let me go back and really briefly mention the dosing levels, because it is confusing for all of us to think about dosing, and we want to make sure everyone gets the information up front. So for Pfizer, for anybody 12 and older, the dose is 30 micrograms per vaccine injection. And for 5 to 11-year-olds, it's 10 micrograms. And for the 6 to 4-year-olds, we're currently seeing a 3 microgram dose. That 3 microgram dose did not meet the non-inferiority criteria for antibody responses. That is, 2 doses of the 3 micrograms in this age group did not give you an equivalent antibody response to older kids and adults. So what we're seeing is in June, the company is going to submit a 3-dose schedule to see if the 3-dose schedule of 3 microgram doses will give you that needed equivalent antibody response. And we'll see those data in the middle of June. Now, Moderna is for 18 and older, their doses are 100 micrograms per dose, given every 4 weeks, given 2 weeks apart. For 12 to 17-year-olds, it's 100 as well. For 6 to 11-year-olds, the dose is 50 micrograms, and they are currently now studying a 25 microgram arm as well. And then for the 6-month-old to 5-year-olds, the dose will be projected to be 25 micrograms. And then there's data there on Novovax vaccine, which again, I have no context for that because I haven't worked with the Novovax vaccine. So all of this is going to need to be spelled out in more detail once these vaccines are reviewed, and we'll have lots of information available. So I want to stop there talking about vaccines, just to mention briefly that we really need to think about treating people who are infected, because this is a way of actually reducing risk of severe disease and hospitalizations and deaths. It's also a way, in theory, to reduce circulation of virus, because what we're hearing anecdotally, this has not been published yet, but we're hearing from a number of sites around the country, notably some of the professional sports organizations where they're using Paxlovid, that there is a major initial reduction in viral load and symptoms within 24 to 48 hours of starting antiviral therapy, and specifically Paxlovid. Now, Paxlovid is a combination treatment of nirmatrelvir and ritonavir. And nirmatrelvir is a RNA-dependent RNA polymerase inhibitor, and our ritonavir is also a protease inhibitor, primarily used for HIV, but it helps to boost the effectiveness of the other drug. And so it is currently authorized under emergency use authorization for treatment of mild to moderate COVID, only for adults, and I'll show you that in a bit, and children 12 years of age and older, weighing at least 40 kilos. And they also have to have positive SARS-CoV infection. So that has not, in fact, it hasn't been shown not to be effective as a prophylactic drug. So if you are trying to prophylax somebody, it has been at least informally, the data aren't fully published yet. It's been put up on a preprint, but it appears that this is not a good drug for prophylaxis. So if you already have an infected individual and they are an adult or a child 12 years of age and older with high risk for progression to severe COVID, including hospitalization or death, then this would be a good drug to consider using in that person to prevent progression of symptoms. And it needs to be initiated within 5 days of symptom onset for best antiviral effects. And I won't, this is something that you can look up, the references at the bottom. This is from the Infectious Disease Society of America, or you can go to idsociety.org and find this table. And what I want to show you here is this circled area, which is, you can consider these therapeutics. This is the Paxlovid here, within 5 days of onset. And for kids, this is for children 12 and older. For children under 12, the only other thing that's available is remdesivir. So if you are not, if you have a child under 12 who has high risk for progression of disease, remdesivir is really the only product available at this point, and that's right here. And unfortunately, this is, the Paxlovid is really easy to give. You can give it twice a day for 5 days. It's an oral therapeutic. And unfortunately, remdesivir is a 200 milligram IV infusion given once a day for 3 days. So that's a little much more complicated to do, but it does help with progression of symptoms. Here's just to show you the different risk groups for consideration. If you actually have a patient like this, you can go to this website or check in with our ID service. But there are the risk groups for giving Paxlovid really have to be people who are either, immunocompromised, unvaccinated with risk of severe disease, vaccinated at high risk, and then at the lowest risk group, vaccinated with some risk of severe disease. And just to know that there are drug-drug interactions, and there are many more than what I put in here, but there's a whole list that you don't need to worry about now. If you think you have a patient, that's the most important thing. If you have a patient you think is at high risk for progression of disease, please check in with ID, and we can help guide you if you really do need to provide a drug like Paxlovid or remdesivir to those children. And then I wanted to end by saying that overall, we know that the disease itself is important. We know that. We know kids need to be vaccinated, but we also know that there are other issues like long COVID, which we think occurs in about 15 to 30% of kids. We don't really understand the pathophysiology or the treatment well at this point. But we also see loss of in-person education, sports issues, socialization, mental health issues, caregiver deaths, and other factors. Mental health issues, I think, been front and center recently. I won't go through all of these numbers, but many direct impacts on mental health in children because of the COVID pandemic. And these need to be really dealt with for basically every child who has had to go through this pandemic. So I think school screening for mental health issues would be very helpful. And I know that the American Academy of Pediatrics has a number of tools for this. Diabetes, there's some evidence that diabetes rates have really doubled over the COVID pandemic. Now, we don't know that that's directly related to the virus. There could be other factors as well. But here's a study from Rady Children's in San Diego looking at their own experience with an increase. Notably, these children are the same as kids who present with type 1 diabetes before the pandemic, with the only difference being these children more likely to require insulin infusion, but otherwise very similar, just a higher rate of type 1 diagnoses. And then finally, to just say that we need to think about this vaccine, the COVID vaccines, in context of other vaccines. So if you look at other vaccine preventable diseases and the hospitalizations we can prevent, we know that COVID is similar to chickenpox and influenza hospitalization prevention. And when you look at deaths, you can see that COVID-19 is really, even though we thought it's only 1,000 deaths, it's still 1,000 preventable deaths. And you see that the COVID-19 average deaths are much higher than for any of the other vaccines for which we currently vaccinate. And you see that we also have racial and ethnic disparities in hospitalizations due to COVID, as listed here. And then deaths. Children who have died, this is 1,092 children who died in the US from COVID. You can see that a third are Hispanic and a quarter are Black children. So we know that this is a racial and ethnic disparity that needs to be addressed. And then when you look at a comparison to flu, a FluNet, which is a national CDC surveillance system, compared to COVIDNet, you see that the risks of hospitalization are about the same length of stay. ICU admissions are higher than they are for flu with COVID. Invasive mechanical ventilation is almost twice as high for COVID than it is for flu, and the rates of deaths for both are about the same. We also know that if you inserted the number of deaths in children for a one-year period from October 2020 to 2021, we are at the 8th most common cause of death for children when you compare to the pre-COVID era for crude death rates in kids. So while the numbers appear to be small to people who take care of adults, they are still very high when it comes to preventable deaths in children. And I just want to end by saying that mRNA vaccines were such a big deal that they were included as vaccine. Vaccine was the word of the year by Merriam-Webster in 2021. But that wasn't the point here. The point to me was that they actually had to change the definition from a preparation of killed microorganisms, blah, 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 to a preparation that is administered to stimulate the body's immune response, because there was so much reaction to that idea that you're injecting people with killed bacteria or other live attenuated organisms. So we also have to worry. I have a whole other section on vaccine hesitancy, but this is why Merriam-Webster changed their definition. So take home, COVID-19 infects children commonly. It can be as severe or more than other vaccine preventable diseases. Among the top 10 cause of death in kids these past 2 years, affects children of color and those with socio-demographic disparities. Vaccines are safe, immunogenic, and effective. And so I will stop there, and thank you so much for your attention.
Oh, Bonnie, thank you so much. A lot to absorb there, drinking out of a fire hose. So the questions have been rolling in, as have the notes of appreciation. So really want to, again, extend our appreciation to you. The questions are coming in kind of 4 categories: long-term COVID and complications, vaccines, testing, and treatment. So I'm going to open with a couple questions that came in from Drs. Ambler and Dr. Crane. Hi, Lucy. Around long-term symptoms. So long-term consequences that you know of or hearing about in terms of cognitive problems, difficulties with attention, concentration, that kind of group of issues, and then also about migraine headaches. So everything that would kind of involve the CNS.
Yeah, so that's a really good point. Now, we here at Stanford are part of a program called the Recover NIH program. Now, that, unfortunately, we were only really included in the 18 and older group. Grace Lee is leading, I'm helping support that group. because of some of our cohort studies that we have. But Grace Lee is also involved with the overall national pediatric long COVID registry. And we're trying to enroll kids at this and adults at this point. What we know is that about 15 to 30% of children and adults are reporting some degree of symptoms more than 30 days out. What we don't know is how quickly that drops off over time. We are seeing neuropsychiatric impacts such as brain fog, mental fatigue, physical fatigue as well as mental. And one of the things that we're seeing is exacerbation of pre-existing psychiatric disorders as well. It's hard to know if it's because of just living through a pandemic, right, or if it's really from disease, but those are things that are being found. And there are efforts to look at pathophysiologic mechanisms. And right now, headaches are another problem that we're seeing. And what I'm understanding is that most of the ways that we're dealing with this is not by antiviral therapy. There's some hint that antiviral therapy could be effective at reducing these, but we don't have good data for that yet. So they're using conventional methods to deal with the mitigation of these long COVID symptoms.
All right, so more to come. Thank you. Next category, vaccines. We've had about 3 questions that have come in looking at the risk of the cardiac risks and the vaccines, and you definitely had a nice slide that addressed a lot of that. Some people were thinking about, though, if you look at it in terms of how do you convey this to the parents, that the risks are small but significant at the same time. So ways we could talk to our families about comparing it to, say, airplane travel or other rare risk activities. What's a way to help convey it?
So this is something from the ID Society, from the Pediatric Infectious Disease Society, from the American Academy of Pediatrics. So get the facts. COVID-19 myocarditis and vaccine, 4 to 8 times higher risk of heart disease, heart problems from the vaccine, from the virus itself, 10 times higher risk here, I can't read it now, of hospitalizations. And this is the same chance as being struck by lightning in one's lifetime if you get the vaccine and you're a boy between 12 and 29, and your risk for myocarditis, same as being struck by lightning. So I think this puts it in some context, and this is available. If you want to, I can send you this slide, and then we can somehow publish this. But it's on the Pediatric Infectious Disease website. It's also part of the Infectious Disease Society of America.
Thank you. It's got a QR code there. It's pretty small, but if people can do a screen grab and get that, that looks like a wonderful handout. We're going to have to add that to our clinic. All right, let's do a couple lightning rounds. We're kind of running out of time here. So quick answers. Do you recommend every child who does a test for COVID do a PCR test, since home kits are not sensitive?
Well, I think it really depends. They do say it's an important thing to go out and get a PCR. If you can, I would. If you think your child is not symptomatic and they're positive, they get a positive test, then I might think about getting a PCR. If they have symptoms, sorry, the gardener's outside. If they do have symptoms and you get a positive rapid test, I mean, I think I would likely believe that. Yeah.
Okay. And are there certain brands of the rapid tests that have been shown to be better than others?
We don't endorse any particular products, just whatever. I would say go with the FDA approved ones.
Got it. All right. Last ones for a couple questions around treatment, Paxlovid in nursing moms.
Oh, good question. I think I would talk to a OBGYN. Because mostly because of the drug interactions. I don't think there's been any teratogenic issues there. Molnupiravir is the problem. Molnupiravir, definitely. I didn't bring it up because it's less efficacious. By the way, Paxlovid has 90% efficacy against progression of severe disease. Molnupiravir is only about 30% effective. And it also has evidence of teratogenicity. So you are not supposed to use molnupiravir in pregnant women, but I don't think that's been the case for Paxlovid so far.
Awesome. Okay, and last one, there have been some, as people come off Paxlovid, rebound in symptoms. Anybody looking at extending treatment from 5 to 10 days?
Yeah, absolutely. So there are studies. So it looks like, I mean, from what I'm hearing from some of my colleagues who do professional sports screening, and then test to treat. So those guys don't really want to get back onto the court or the field or whatever. I mean, everyone wants to get back, but so they especially do. So I'm hearing anecdotal rates of about 1 to 2% rebound. We don't understand it, but actually, if you look at the original Paxlovid paper, it was there in one of the supplementary graphs, which wasn't in the main paper. But if you looked at it, about 4 or 5 people out of the 100 that were studied, you saw that at day 10, some of their viral loads went back up and they were symptomatic, but it was equally present in the placebo as well as the treatment group. So we don't know what that means. So they are studying, trying to extend the course or see what should be done, but that's not currently recommended at this time.
Oh my goodness. Well, as always, more to come, more studies being done, and we'll have more recommendations. It sounds like along those lines. Bonnie, thanks again. Really appreciate your time and all your insights, and want to give a shout out to Alan Schroeder, who this was his brainchild. He wanted to help make sure we all stayed up to date. So we will continue to bring these updates to the community as we can. And thanks so much. There's still some questions in the chat. I'll do the best that I can to summarize those and get them out. Okay, so thanks everyone. Have a wonderful day.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.